Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's certification, offering specialty, subspecialty, or advanced practice board certification, with information available at www.aacn.org/get certification. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. I'm Andrea Schmidt, Clinical Practice Specialist at AACN, and I'm joined by my co-host, AACN's Chief Clinical Officer, Vicki Good.
Hi, everyone.
So today we are going to be diving into delirium. Now, I think most of us know that delirium can be a very devastating complication for patients and family, and I think more patients are affected by it than many nurses realize outside of the ICU. It can affect up to 85% of vented patients, but also 65% of non-vented patients. And that can occur outside the ICU and have long-term consequences on both patient populations.
It is easy to think as delirium is only affecting the elderly and pass it off as sundowners, but the reality is it can happen to anyone at any age. For our guest, Erika Breivogel was a 23-year-old nurse when she found herself as an ICU patient, experiencing delirium on the other side of the bed.
Welcome, Erika, and I think we're both really looking forward to hearing your story. We appreciate you joining us today. So if you could share with our listeners, how did you go from nurse to patient?
Yeah, so definitely. I was a rapid response nurse in the ICU that I work in. And what that kind of entails is you check on all of the patients in different ICUs. And that night, the CV called me and they had a heavy surgery load and they had multiple arterial femoral sheaths that need pulled, which, as you guys know, like taking those out, you have to hold like manual pressure for 30 minutes and can be kind of intensive. So I am a day shift nurse, like through and through, but I decided to work a night shift. That was like the first thing that's the impending doom about this story. The day shift going to night shift. But so I went down to the CVICU and I spent over 3 hours pulling arterial sheaths. I get a call from the trauma ICU asking me to come up and help them do something. And I start going up the stairs and my back really starts hurting. And I'm like, oh, it's just from pulling all those sheaths. It's like no big deal. But when I got to the top of the stairs, I thought I was instantly going to throw up and get sick. And I had this like feeling like I was going to pass out. So what do? I freak my mom out, call her, being the 23-year-old girl I was, called my mom in the middle of the night. And she's like, you need to go to the hospital. I said, Mom, I'm at the hospital. And she convinced me to go to the ER. At this point, start having stabbing abdominal pain and really crucial back pain. And then I just started feeling achy and like something was not quite right and I couldn't explain it. But anyways, I ended up going to my car and I got really lucky, but I passed out in the parking garage in the middle of the night. And when I woke up, I was very confused. I was like looking around in my environment and I didn't know what was going on. I somehow made my way to the ER that in the hospital I worked in. And when I got there, guess what my vital signs were? Not good. My heart rate was like 170, 180. My blood pressure was in the 70s. I was breathing about 22 times a minute, and my respiratory rate was 18. So I was told. And my SATs were only like the low 90s. So I get in there, they get labs, and what do you think came back positive immediately? My lactate was like 3 to 4. My white count was like greater than 20. And they take me in, I get all kinds of scans, but long story short, I ended up having an obstructive kidney stone in my right kidney. A little bit of background history of me. I'm very healthy. I don't have any medical problems, but I was born with a congenital kidney disease. And so I had some surgery as a kid. So my urology anatomy is a little bit different. So this may have complicated. It shouldn't have, is what the doctors said. But so I'm in the ER, I'm getting all kinds of medicines, but my blood pressure is not coming up and my heart rate's not going down. So I met the SEERS and sepsis criteria. So, I got admitted to the ICU that I work in. So I was working at that time at a smaller hospital. So it's had to be admitted to the unit I worked in. And let me tell you, that was quite the experience. I like roll up and all my coworkers look like they're going to cry and very upset. And so I end up, do all the things, end up going to surgery. And my surgery was complicated because of my anatomy. And what I do remember is when I woke up, it was in an environment that I did not recognize, and my throat hurt and my hands were tied down. And I tried to sit up and I couldn't sit up. And so, me being the nurse that I am, I looked around and I'm like looking at my hands and I realized, oh my gosh, my hands are tied down. And so then I tried to talk and like scream for help because I start panicking internally, right? Like my hands are tied down. I don't know who this is or what's going on. And I realized I can't talk. So then the nurse brain kicks in and I realize that I'm intubated and I don't see anybody. So you know what I did? I start banging on my side rails. Like I know that's going to get somebody's attention as a nurse. And some people come around me, don't recognize them, and they're telling me to take a slow, deep breath. Erika, calm down. Take a slow, deep breath. And I can't, right? Like everybody knows when you're trying to like breathe through a vent, it's like breathing through a straw. Well, they didn't like me trying to sit up. And so, whatever, I got some medicine and went back to sleep. And then the next thing that I truly remember is I woke back up in the ICU that I worked in and I didn't have the breathing tube in. So I think I was in the PACU at that time, is what I'm thinking. So that evening, I was doing okay. My heart rate was still high. I got like 104, 105-degree fever. Had to be put on a cooling blanket, wide awake, which is miserable. And then that night, I kept looking up at my monitor when I'm sleeping because it would go off. And I look up and I keep going into VTAC. And I look over at my mom and I was like, that's not good. And then I passed out, like scared the ever living daylights out of her. So I start going like kind of in and out of being coherent. And the next thing that I remember is I hear RRT in whatever room I was in. I see the code card, the big orange intubation box being pushed at me. People start ripping my gown up and putting the pads on me. I see like it's just mad chaos, right? Like everybody's freaked out because it's Erika. Erika's the nurse. Erika's the patient. Like, and I see everybody's eyes. Everybody's eyes are so heavy and they look terrified. I'm already terrified because, I'm very uncomfortable in this situation to begin with. My coworkers taking care of me. But I'm also like, no, as a nurse, like what I'm seeing is really bad because I looked up and now my blood pressure is like 70s and 60s. And then I kind of like lose consciousness at this time. But I remember I couldn't breathe. I was on a couple liters of oxygens initially, but what ended up happening, I ended up going into flash pulmonary edema. So they slap a BiPAP on me. They put a central line, they put an art line in, I get started on Levo. Then they tried to give me some Lasix. And I remember being on the BiPAP for a little bit of time. So the next day I get a little bit better. I graduate in the day or two from the BiPAP. And when I wake up, I felt off. I don't know how to explain that. But then that evening, a couple days after being in the ICU, one of my really good friends, Jessica, was my nurse. And, I was super excited because I really liked her. But on a specific evening, I remember waking up in a panic. And when I looked around my room, I saw millions of spiders crawling all over the bed, all over the walls. And I start to panic, right? Because I don't remember in my brain that I'm in the hospital. I just see millions of spiders crawling all over me. And I start to panic. So I start pulling all my IVs out, which I didn't know they were IVs. I start trying to get out of bed. Well, then all the monitors are going off, the call light, the bed alarm, and all these people come in. They're like, you have to lay down, Erika. You have to lay down. And then I'm assuming I got like a benzo at that point because I remember like passing out. And then when I woke up, I remember being terrified. The spiders were gone, but I remember like looking around and just panicking and just I had no recollection of what was going on. I didn't know I was in the hospital, but what I do remember is Jessica came up to me and she held my hand and she kept saying like where we were at. She's like, okay, Erika, like you're in the hospital and this is what's going on. And I remember one specific thing I remember about her is she grabbed my face and she's like, Erica, you are safe. And I think that probably helped me the most to get through that night because I literally felt like somebody was going to murder me. That is the amount of fear that I had inside of me, and nothing anybody can do could console me. Um, that evening, I got, through the worst of that. And then, over the course of the next several days, I graduated from the ICU, was on the med surge for a couple of days, and I was able to go home. So that's kind of in a nutshell my story of what kind of happened and some of the experiences I encountered.
That sounds terrifying. I mean, it really does. I'm glad that you're okay and that you survived it. I just can't even imagine what that would feel like, not really knowing what happened and having all those disconnected pieces in your head. And we don't really get to talk to patients when they leave the ICU, right? So we don't necessarily hear these stories. So I really think it's great that you're sharing your story because I think a lot of people may get a better understanding of what that was like and what that could feel like, and the possibility of having PTSD from this experience has got to be, you
Yeah,
know,
it was tremendous. When I had to go back to work, I could not walk back by my room because I worked in that ICU. I just remember I walked by that room I was in and I instantly just had like a panic attack, anxiety, and I had to leave and I couldn't return to work for several months just to work through that PTSD.
I can imagine.
Yeah, and I mean, how many times have we had patients that wake up and all of a sudden start pulling at things and we just think they're pulling at stuff and don't understand that they could be experiencing delirium, and seeing things that don't exist and all of that kind of stuff. And, back when I was a bedside nurse, it was just, oh, get them safe, tie their hands down, and move on. And we've learned so much through the years about delirium. And I know there's now multiple types of delirium. So can you help us understand the different types? Because I mean, obviously now you've become an expert on delirium after unfortunately starting out the wrong way to become an expert.
Yeah, absolutely. So, actually, the least common is what most people think of when they think of delirium, which is hyperactive. So that's like that crazy person that's like punching and kicking and getting out of bed. And then the other form of delirium is hypoactive delirium. Now, that is your cute little mammal that's laying in her bed and she doesn't ever say anything and she just smiles at you, but she also doesn't like know what planet she's on. So she's just kind of like laying in the bed. Um, and then mixed delirium is just a little bit of both. So I think we probably see hypoactive is the most common. Maybe some mixed might be what we see, but they're just people that just have no emotion. They're flat affect, and they just look at you.
So which type did you experience?
I want to say it started out as hyperactive when I was in that panic mode, but in the days followed, I just remember like I just didn't care about anything. And I just like people would be like, oh, you need to eat breakfast. And I was like, I guess, like I just had no emotions. And like I remember like my mom and sister always telling me like I just didn't want to participate in anything. And I kind of just like laid there and then I would sleep all the time. Because I was in like such a brain fog for even months to a year or so to follow after that. So I think it definitely started out as hyperactive, but then developed into hypoactive.
And I think that, the hypoactive is harder to recognize, right? Because we're used to, somebody wants to jump out of the bed, they're climbing over the bed rails. As Vicky mentioned, we would restrain them before or just give them something to sedate them, right? Which just makes it worse, becomes this vicious circle. But I think with hypoactive delirium, I used to see this in rounds all the time. You would have the little old people and they were just laying there and not really interacting, just like you're saying. And, I would say, did we do a delirium screening? Well, they're alert and oriented times three. Well, I think that's hard because you can be alert and oriented times three and still be positive for delirium. And I think that that is a key piece that, people sometimes can really miss. So, do you have some insight into, I think, some of the differences that you explain to your staff on how to, identify it, what to look for, etc.
Absolutely. So there's a ton of risk factors with delirium. And, I'm primarily in medical ICU, but it's advanced age, anyone that has alcohol or drug abuse, anybody that's sleep deprived, anybody older than the age of 65, signs of infection. So for me, that's checks like all the boxes. Um, and then, of course, like sedation. So, any sort of benzos, propofol, anesthetic, all of those things on top of everything that I mentioned are all severe risk factors. And like I said, like you mentioned, people can be a GCS of a 15 because the confusion assessment method or the CAM-ICU, it is an exam about cognition and inattention, checking for like disorganized thinking. It has nothing to do as an orientation exam. So I get that all the time. Like people are like, oh, again, report that patient's a GCS of 15. They're 20 years old. They're fine. And then I go in and do my full CAM ICU and they're completely positive. They're on another planet is what I say. So that would be like the biggest thing is that even though your assumption is that they're fine, they can be not. And I mean, think about me. I was 23 years old. I was an ICU nurse. You would think I would be the someone that would have no predisposition to delirium, but here I am, class A example of I had it and I had it severe. And it could have been a lot worse, which I'm very grateful. But that's my biggest thing is you assess every patient, no matter if they've been in the ICU 5 minutes, 5 days, or 5 weeks, is what I tell my staff.
I think it's a hard thing to break, a harder habit to break because, everybody's like, well, you're alert and oriented, it's fine, but really to enculturate them into doing all of the evidence-based assessments.
And you were really lucky because you had a personal connection to the nurses that were there. So how do we handle for our patients that don't know anybody when they walk into this situation and they don't have family present? How do we get them reconnected with reality or current time and current place? What
Yeah,
is
so
practices for that?
Yeah, so the biggest thing is always make sure your patients have like if they need hearing aids or glasses. That is like the biggest thing. Like I don't have glasses, but I have like friends that they're blinder than a bat if they don't have them. So just imagine if you're like sedated and confused, it would be even worse if you couldn't see what was going on. So always advocate for those or, get them from somewhere else. The other thing is we want lights on during the day. Now I'm guilty of it. Like sometimes I have that agitated patient and I want to turn the lights off, make them go to sleep and let them be, but that's actually not good for them. We want the lights on during the day, lights off at night. Cluster your care as much as possible. And then I always tell my staff, like the biggest thing you can do is you go into your room and you explain to these patients what you're doing. Hi, my name's Erika. I'm your nurse today, and I'm going to come in. I'm going to give you some medications, and I'll explain to you what they are. And right now I'm going to use this mouth swab. I'm going to clean your mouth. Like I see people all the time just go in, stick the mouth swab in their mouth, turn the patient, tie their restraints, and leave, and not say anything. Put yourself in that patient's footsteps and just think about that for a minute. You wake up from a general anesthetic, have no idea what's going on, and then someone's shoving something in your mouth, your hands are tied down, and we turn and position our patients in a very uncomfortable way. So I can tell you, like, if you explain what is going on, say, hey, you've been in the ICU for 5 days, you came in for urosepsis, you're on a ventilator. We've been contacting your family, and like I try to use the detail specific things, like because I work in a big city in Indianapolis, and a lot of people come from across the state. So, I'll say, hey, I talked to Judy today, and she let me know what's going on, and she's taking care of Poppy, that the dog. Everyone always wonders about the dog, but try to incorporate those details as much as possible. Because when you incorporate personal details from someone's brain, it helps that part of the brain that helps with delirium. And again, you want to orientate your patient. I know I said it's not an orientation exam, but you want to say, hi, you're at this hospital, you're in Indianapolis, it's November 17th, it's 2025. It kind of helps bring that patient back to reality. And that's what we are trying to do with delirious patients is not necessarily reorient him, but get them back into reality from this dissociative state.
That makes total sense. And I think that sometimes when that doesn't work, right? So we've done all we can do, we're trying to reorient, what's the next step? What do we
So,
do? There weren't a lot of treatments, right?
mhm.
Especially medication, but what other things can we do, especially for maybe a newer nurse who is not really super familiar with delirium and some of the treatment or thing, besides the hearing aids and the day-night issue.
Yeah, so the only proven research treatment for ICU delirium is early mobility. Now I get it. Like I'm an ICU nurse, right? Like all my patients have a vent, an art line, a swan, a CRT machine, a cooling blanket. Like I get that it's like 100 different devices, but the research is out there. Like get your patient to a cardiac chair, chair position in the bed, actively have them participate in stuff. Like, if you're giving a bath and your patient's like awake on the vent, have them attempt to like wipe their arm off or like let your patient, I know it's so hard, but untie those restraints and let them itch their face, let them use the washcloth to wipe their face. All of those aspects of including the patient in the care, it's not just to make them feel better. That is stuff that's going to help prevent and treat delirium. Now work with your physical therapist. We love to get patients, you start getting them on the side of the bed, then you can like get them to a chair and then you can ambulate with vents. The biggest thing, there's a lot of evidence and research out there about getting our patients' feet to touch the ground. That is a big thing that helps with like the perception of the space with the brain. So I always tell people like, you can sit anybody on the side of the bed and you can get their feet on the ground. Now I get there's going to be, those contraindications, obviously, but get their feet on the ground and try to take off the restraints. You want them to be in the least restraints as possible. Now I know there's policies and things on that, but if you're going in there and doing your assessment, let your patients breathe. Like imagine just being strapped down to the bed and can't move. That does so much. It's so debilitating for people's outcomes in the hospital. So like I said, the biggest thing is early mobility. We've got to move these patients. We have to be moving them, letting them actively participate every time that we're doing care. And I understand like the culture of that is very challenging and that can be a hard thing to give up, give up that freedom to the patient to keep them safe.
I think you're outlining some of the challenges in this situation because we've all been brought up. We have our current practices that we've always done. But oftentimes, especially as we progress in our career, we don't realize how dangerous some of those common practices can be. So if you could stop a nurse from doing one common practice, what would it be?
The biggest one would be probably sedating people because I don't want to see them move. People, and I'm guilty of it, like I've learned a lot in this research, but it is detrimental to people's permanent brain dysfunction to just sedate someone or give them endless amounts of narcotics because we don't like squirrely patients. I like the perfect patient that lays in the bed, looks super pretty just as much as anyone. But it's okay, like to have less sedation and like keep your RAS score at a +1. I know that that's uncomfortable. Like, trust me, I get that. Um, but to be able to get these patients on the least amount of sedation as possible is the goal. There's so much evidence and research stating just how bad it for these patients to be on the vent sedated for so long. That is the goal. And I would tell new nurses, you got to try it out. You got to trust these patients. Of course, patient safety is going to be our number one priority. But I promise the more you do it, the more comfortable you're going to be with it.
Mhm.
100%. And I think that, I want to circle back for a second to the mobility piece because I think as nurses, when we think of mobility, right, we think of walking. And obviously that would be the end goal is to ambulate, whether you're on a vent, whether you're not on a vent, right? But there's all these steps that are in between. And I think, short staff, high acuity, whatever it may be, I think we have to think about utilizing the resources that we have such as the bed, but also if your hospital happens to be equipped even with a ceiling lift or a sit to stand or something like that, that even if you can get them in that, and then lower their feet to the floor. You don't have to necessarily worry about them having all the trunk strength. I think there's so many other things that we can think about to help sort of grow the mindset, right? And get that mindset to change. But I also think that this, for the non-vented patients, maybe they get out to step down and they're no longer on a vent, they still may be delirious out there, right? And now we have a higher patient ratio in that progressive care area. So now what? What advice do we have for those nurses when they should be in a chair and not tied down, right?
No, absolutely. That is a big challenge. I know staffing is so challenging. It's a nationwide problem. I always tell people involve these patients' families as much as possible. Like, trust me, I used to be the nurse, like, let's get the family out of the room. I don't want these people in here. But I'm telling you, like, if you don't have the resources to get your patient up, tell the family, like, teach them. All of us can teach families to do simple range of motion. We can have our patients' families start talking about home memories, reorientation, just reminding them that they're in the hospital. So family engagement, and that is a part of the ABCDEF bundle. Family engagement is the F. So, definitely the other thing I like to do is I plan my day out in the morning, and I know ICU or the med surg things happen, crazy things come up, but try to set a goal and stick to it. So if, let's say, my bath is due at noon, okay, I'm gonna for sure do my mobility with my bath at noon, and that gives ample amount of tune to other providers. There's gonna be those days where this is not possible, but I have found in my practice that the more time I give people, the more voices that hear about this, the plan is more successful than it just being a spur of a moment and then the shift is in. So that would be my advice on that.
But Eric, I know that there is just so much research out there now on delirium and so many different resources. So if I'm a nurse trying to really educate myself on this, it's a bit overwhelming. So what would you recommend? What resources do you recommend for our listeners?
Oh, definitely. My biggest piece of advice would be the Society of Critical Care Medicine. They really outline each component of the bundle and they break it up letter by letter. And they explain, what to do and different interventions. And then they also give amazing data and statistics on delirium because I always tell people, like, I don't like to scare you, but I mean, just like you said, 85% of mechanically ventilated patients have delirium. Like, let that sit in a minute. And so when you start reading these articles and you start getting those facts, that helps like spread the awareness and the importance of the delirium. So they have beautiful pictures, beautiful articles, all kinds of patient examples, and also like the PADIS guidelines with the Society of Critical Care of Medicine. So that's our number one go-to.
I think, to the training piece, obviously, I would assume, when I did this way back when, I trained using ICUdelirium.org, which came out of Vanderbilt, which I don't know if they've joined forces with SCCM and collaborating and things, but I think also effectively making sure they understand how to properly do the RAS and how to properly do the CAM, because obviously, if you are off on that, you may not appropriately, recognize the delirium. So I think that that's an important component. Do you have any recommendations for a good way to make your training stick?
So I do. What I do at our hospital, we have laminated cards in each patient room, and we have them. And I tell my new nurses, take that to the bedside with you. And on the back is the RAS education as well. So take it to the bedside, and it's okay that you have to learn to read it until you memorize it. Like, trust me, give it a month in the ICU as a nurse, and you'll memorize it. But having that resource, because you want to stick to the algorithm of the CAM ICU. So having it in there, and if you have to repeat it, you have to repeat it. But you want to stick to the algorithm of the exam, but just having it readily available and talking about what a RAS is. I think that's one thing all of us as ICU nurses can work on, is recognizing that it's okay. If your RAS is a -3, then we need to intervene on that, just recognizing it. Like, I come in time to time and I'll see like people's are documenting -2, which is light sedation, right? Like, go in the room and I'm like, hey, Erica, can you open your eyes? And like, crickets, nothing happens. So again, that's another key important thing about delirium is, like you mentioned, successfully identifying your appropriate RAS score. And that is the purpose of the RAS and the CAM is come down on your sedation, come up on your sedation, but you need to make yourself very familiar with what the RAS and the levels of the RAS, because that is how you're going to adjust your sedation, go down on it. And like those are, like I said, the sedation is a huge portion of ICU delirium. So successfully take some time, read over the RAS, and ask questions about it because it is a complicated thing. Use your educators, your nursing professional development department, and it can be a challenging thing for a new nurse. So read those resources.
So, Erica, as I'm sitting here thinking, some of our listeners may not be familiar with the ABCDEF bundle is. And I know some of us started when it was just 3 or 4 letters. So, would you just remind quickly the listeners on what is the full bundle?
Oh, yeah. So A is assess, manage, and treat pain. B is both spontaneous breathing trial and spontaneous awakening trial. C is choice of analgesic. D is delirium. E is early mobility. And F is family engagement. So this bundle components, it's just working like everything that we've talked about, like making sure the patient's pain is controlled, and we're using, the appropriate medication. So if someone is a chronic narcotic user, we want to add their home narcotics on and not just, snow them with too much fentanyl. And sedation. We've talked about how propofol is not a good drug. So the PADIS guidelines are talking about Precedex being more of it. And delirium, like how are we treating it? Are we needing antipsychotics? Are we getting sleep hygiene? And then obviously early mobility, getting the appropriate physical therapy departments, and then family engagement, getting them to interact. So these bundle components take a look at the whole picture, and it's working with different departments and every aspect of the patient's care, to able to liberate them from the ventilator.
Thank you for sharing that with our listeners, especially if somebody is not familiar. And one other thing I want to say is this. I think as a nurse, one thing we need to do is advocate for if a patient is already on something at home, let's say an SSRI, or they're on some other type of medication for mental health, a lot of times, and I don't know if you found this in your practice, but I saw it in mine, they get admitted to the ICU and we do the med rack and the doctor's like, don't order, don't order, don't order. And then I'm like, oh my goodness, 3 days later, now they're going out of their minds because they're withdrawing from their SSRIs because they're cutting it. And I think as a nurse, we need to advocate to make sure we're not taking everything away from them. Do you agree?
Oh, absolutely. I mean that is just, you're talking about messing with all your neurotransmitters in your brain. Why would we do that when you're in the hospital? Let's not practice here. Yeah, getting all of those home medications, getting the patient on their home routine as much as we can, just to try to not shock their brain or add any other, added other problems. Absolutely.
Because it becomes an ICU problem. I know sometimes they'll say it's not an ICU problem, but it's going to be one if I can't get them extubated and they go become delirious, right? So just as
Absolutely.
to make sure we're advocating for the right things. So I think you have, provided incredible insight about delirium for our listeners. Your story is, quite frankly, unreal, like terrifying and unreal. I said that before, but I like can't get over it. And I'm really sorry that you had to go through all of that. But thank you for taking a lemon and making lemonade out of it because I think, you're helping so many people. So what is one thing you would want our listeners to take away from today's podcast?
My biggest thing is be uncomfortable. Be the one that turns down the sedation, be the one to get the patient up to the bed, be the one to tell your patient 800 times in your 12-hour shift, this is what's going on. This is why I'm doing it. Because I am telling you, what you are doing every day in your practice is help saving a patient's life. It is preventing permanent brain cognition issues, and it's keeping that patient's quality of life, what it was before we came to the hospital. So be that small person that everyone looks at like you're kind of crazy. Like I turn my lights on, I go in there and I tell my patients, this is what we're going to do and this is what's going on. That is be that 1% in, your nursing staff to go the extra mile, to do things that may seem not as important, but they are important. Imagine you come to the hospital and you can't go back to your regular life. You're in a facility, you have to retire. I mean, that's like really scary to think about. I mean, it's happening with patients that are in their 30s and 40s. So be the person that makes a change for that patient, even if nobody else notices, but you will notice and your patient will notice, and they will thank you for the hopefully many years that they have for the rest of their life.
Well, Erika, thank you so much for sharing your powerful and personal story. You've been vulnerable with us, and I just appreciate it so, so much. And hopefully, these insights will inspire and educate many of the nurses in our profession. So, thank you so much for sharing your time with us today.
Absolutely. And thank you for having me.
And thank you to our listeners for joining us today. We would love your feedback and any ideas for future podcasts at podcasts@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's certification, offering specialty, subspecialty, or advanced practice board certification, with information available at www.aacn.org/get certification.